Welcome to Pediatric Skeletal Growth Disorders. We're going to be discussing the two on the slide, and then we'll move on to juvenile arthritis and osteogenesis imperfecta, which will be the end of this pediatric musculoskeletal lecture series. So this one is an avascular event that affects the epiphyses of the femur and prevents further growth of the ossification nucleus, resulting in increased bone density. As the bone is subsequently reabsorbed and replaced by new bone, the femoral head tends to flatten and enlarge. So our clinical manifestations. The child will present with a painful limp that is going to be exaggerated by activities like walking or running. It's a 5-stage progression over a 1 to 2 year period. So stage 1 is when the epiphyse begins to show the results of ischemia, and they'll have synovitis that produces stiffness and pain. Stage 2, necrosis begins. X-rays show a reduction in size and increased density of the femoral head. This has bone weakness. The bones weaken and it dies, causing a collapse of the femoral head. In stage 3, fragmentation stage, in which avascular bone is reabsorbed, healing occurs as new bone is formed. Stage 4 is the reossification stage. Femoral head and neck begin to reform, and stage 5 is healing. Your assessment for this assessment reveals loss of internal hip rotation and limited abduction. Determine how long the child has been limping, as well as the pattern, timing, and severity of pain. Physical examination of the extremity may reveal muscle wasting of the thigh and buttocks as a reflection of disuse. So the child kind of not using it as much will show the muscles will start to kind of waste away in that area. Shortening of the extremity on the effective size will indicate the collapse of the femoral head. Treatment, so we want to restore and maintain adequate hip range of motion. We want to prevent complications like the femoral head collapse, any subluxation of the joint, and we want to preserve the femoral head and shape during healing. The initial therapy, probably one of the most important parts, is making sure that we do that activity restriction. The child needs to rest and limit all weight bearing to reduce inflammation and irritability of the hip. And depending on the age of the child will be how hard it will be to really implement this. Just because if if you have a child that's smaller, we can carry them around. If they're larger, it makes it harder for us. And then, they really need to be activity restricted with rest and not weight bearing. Pain management, we can use non-steroidal anti-inflammatory. Physical therapy will help with range of motion exercises to restore the hip motion. We do some additional interventions like traction. It's applied in rare cases to stretch tight abductor muscles and improve the femoral head. We can do bracing, which abduction braces or casting of the femoral head. And then there's surgical, where if those conservative measures fail, we'll do a surgical reconstruction of the joint. Prognosis. This is a self-limiting disease. Early and efficient treatment definitely improves outcomes. Best prognosis is in children 5 years and younger, just because there's more cartilage at the epiphyseal. We have an increased risk of degenerative arthritis in children older than 8 years with this femoral head deformity at diagnosis. Diagnosis and timing. Delayed diagnosis can lead to more significant femoral damage before treatment. Interventions that we want to do with this kiddo. So we want to facilitate appropriate activity. The child still needs to be able to meet their developmental milestones and tasks, and children can become very frustrated and angry when they're unable to meet their physical and social demands of their peers. As nurses, we need to be aware of those and alert to those subtle indicators of rebellion and uncooperativeness. Sometimes older children will adapt quickly, um, but we just have to be mindful of it. If a brace is prescribed, the school nurse and teachers should be involved in discharge planning so they're aware of the equipment. And then teaching home management. So, nursing care should focus on home care management. The family needs to clearly understand the need for care adherence and the role it will play in the healing process. We need to teach parents to perform neurovascular assessments, understand what's normal, what's not normal, and when to seek medical attention. The nurse should also help parents identify skin and safety issues related to the child's mobility restrictions and the use of the brace. Physical and occupational therapists are important resources for the parents and the patients. SCFEs. Shearing stress causes the femoral capital epiphyseal to displace from its normal position on the femoral neck. Slippage is related to increased stress on the proximal femur during the time when the epiphyseal plate is thinning in adolescence. Hormonal changes during adolescence cause the growth plate to thin. Increased weight and height places more stress on the epiphyses, which leads to a slip of the femoral neck relative to the femoral head. This displacement typically occurs in the posterior and inferior direction. The resulting deformity involves upward anterior movement of the femoral neck. Slippage may occur gradually, acutely, or acutely after weeks of mild symptoms. SCFEs require immediate medical treatment. Manifestations. The classic symptoms are going to be limp and pain. Pain may be located in the groin, the thigh, or the knee. Pain is intermittent and worsens with activity. Knee pain may lead to misdiagnosis, even though the problem originates at the hip. The affected leg is often externally rotated. Diagnosis is suspected based on clinical presentation and growth stage. We do x-rays of the kid in a frog leg position, and this is usually confirms our diagnosis. Treatment for our SCFEs. The adolescent is admitted and placed on bed rest to avoid worsening the slip. We can do an internal fixation, is the most common treatment to prevent further slippage. Severe slips may require reconstruction and pinning. Post-operative care after surgery, the adolescent will use crutches with partial non-weight bearing for 4 to 6 weeks. Depending on the severity of the slip and procedure, nursing care is similar to care for children in traction and post-surgical recovery. Nursing responsibilities. We need to assess for SCFE in adolescents who report any knee or thigh pain. We want to teach and assist with isometric exercise and crutch walking, and we want to support for lifestyle and recovery. And we need to think about if we're having an overweight adolescent, we want to encourage healthy nutritional habits and avoiding high calorie foods. So now we're going to move on to juvenile arthritis and osteogenesis imperfecta. Juvenile arthritis, also sometimes known as juvenile idiopathic arthritis. This nearly affects 300,000 kids and teens in the United States. It's also known as pediatric rheumatic disease, and it's an umbrella term to describe the inflammatory and rheumatic disease that develops in children under the age of 16. Most kinds of juvenile arthritis are autoimmune or autoimmune inflammatory disease. The immune system is confused and releases inflammatory chemicals that attack healthy cells and tissue. In most juvenile arthritis cases, we end up with joint inflammation, swelling, pain, and tenderness. But some have like few or no joint symptoms, and they really only have skin and internal organs. The exact cause is unknown. Research believes that certain genes may cause juvenile arthritis to activate when the body comes in contact with a virus, bacteria, or external factors. There's no evidence that food, toxins, allergies, or lack of vitamins, minerals cause the disease. Treatment, there's no cure for juvenile arthritis, but when early diagnosis and aggressive treatments, we do see remission. Chronic inflammatory disorder of joint synovial is considered one of the most common rheumatoid conditions occurring in children under age 7. Juvenile idiopathic arthritis is diagnosed when the client presents with the following symptoms for a minimum of 6 weeks. So we have continuous arthritic pain in a single or multiple joints, repetitive fevers up to 103, systemic indications appearing as a pinkish reddish rash on the legs, arms, and trunk, and the exact cause is unknown. The child's immune system attacks the synovial lining of the joints. So the diagnostic evaluation for this is pretty intense because we need to rule everything else out and we need to rule this in. So although there's not a definitive test available for this, criteria starts with onset before 16 years of age, arthritis in one or more joints for 6 weeks or longer, and then exclusion of all other causes. So some of the lab tests we look at is an ESR and a CRP. They may be elevated, but not always. Leukocytosis is common during a systemic juvenile arthritis exacerbation. Anti-nuclear antibodies are common in juvenile arthritis, and it's not specific for arthritis. It helps identify children at higher risk. Imaging and studies, we can do plain x-rays. These are the best initial imaging. It can show soft tissue swelling. It can show joint space widening due to increased synovial fluid. Later films could reveal osteoporosis, narrow joint space, erosion, subluxation, and ankylosing. We can also do an eye exam. The slit lamp exam is necessary to diagnose if we're having uveitis, which is the anterior chamber of the eye inflammation. This is the most common in ANA positive girls. Importance of routine examinations, early diagnosis and treatment are really essential to avoid or minimize those potentially, threatening complications that can occur. Management, there's no cure for this. We want to focus on controlling pain, preserving joint function, and minimizing inflammation. So outpatient care is a mainstay of treatment. Lengthy hospitalizations are really rare for this. But again, that means the parents are the ones being the caretakers. So we got to give a lot of education to them so that they can keep this child moving on the right path forward. It's a very comprehensive approach. We want to do medications, therapy, diet, and psychosocial support. So when we talk about medications, your first choice is always going to be a non-steroidal anti-inflammatory drug like naproxen or ibuprofen. That's going to give some analgesic and anti-inflammatory effects. Education on the potential side effects of those are really important. We can also use disease-modifying anti-rheumatic drugs, which are DMARDs, DMARDs. That example of that would be like methotrexate. We have to guide usage based on disease activity and prognosis, educate on the risks and monitoring requirements. We can also use biologic DMARDs, which again are used when the former ones are no longer effective or they're just ineffective to begin with. These do place us at an increased risk for infection, so monitoring is really important on those. We can also do glucocorticoids, which are going to help with anti-inflammatory. We use those really during acute cases and lots of education on side effects because we know long-term steroids can definitely affect the kiddos. We don't want to use opioids just because this is more chronic condition, and we don't need to get them addicted to them. And they also, opioids don't really relieve pain. They make you not care about pain. And we want this child's joints not getting hurt more because of their doing something because they don't care because they're on opioids. Physical and occupational therapy are really good too. All programs should really be individualized for these kids, and our focus is on preserving function and preventing deformities. We can do home exercise programs, which is critical for maintaining mobility. Moist heat is really good because it kind of relieves that joint stiffness and discomfort. And then sometimes we do nighttime splitting to help minimize the pain and discomfort. A little bit more about the nursing management on this. So, our assessment is going to be monitoring their general health, how's their joint status, and how's their overall emotional well being with this. Pain relief should be both pharmacological and non-pharmacological. Again, non-steroidal anti-inflammatories are good, opioids are bad. We want to promote general health. So, good balanced diets, adequate rest, routine medical care. We can do things like a really good firm mattress for sleeping. We can help them and get, a sleeping bag keeps them extra warmth, and that warmth is better on their joints. Electric blankets are good for increased warmth or joint discomfort. Children are also encouraged that they need to be going to school and continuing with a normal life, even if they're having a little bit of discomfort. Remember, we need to be worried about, their psychosocial development and meeting those Erickson tasks and getting their Kohlberg and all of those things, right? So we just want to facilitate adherence um, and get those kids to school. We want to involve the family in treatment plans and educate them on medications. Comfort measures, again, we're looking at things like heat therapy, pool exercises, adaptive devices for daily living. Again, heat is really good for relieving pain and stiffness. Moist heat is sometimes better than just plain heat. So with moist heat, you'd be looking at like bathtubs, hot tubs, whirlpools, things like that. And then support for the child and the family. We need to address emotional and practical needs, recognize stress and provide support, encourage normal activities. So help the family maintain normal routines. School is considered a normal routine. And then resource referral. We want to connect family with support organizations like the Arthritis Foundation. And then our last topic for this series is going to be osteogenesis imperfecta. So this is a rare genetic disorder characterized by bones that fracture easily. It can be autosomal dominant in most cases, and autosomal rare, recessive, which is rare. Genetics. So I guess we have defects in some genes um, that affect type 1 procollagen synthesis, and this results in faulty bone mineralization, abnormal bone architecture, and increased susceptibility to fractures. There's multiple types of this, 12 types. Type 1 is the most common and the mildest. Type 2 is more severe and considered lethal. Type 7 and 8 are the autosomal recessive, so those are the rarest. And then your clinical features really are variable depending on the types that it is. But common symptoms are going to be the varying degree of bone fragility and deformity, usually a short stature. Blue sclera are one of the big ticket items, hearing loss, and then dentigenous Imperfecta, which I might not be saying that right, but it's on the board so you can see it. And it's a hypoplastic discolored teeth. So those symptoms, the blue sclera, the teeth discoloration, the short stature, the bone fragility, and the hearing loss are all usually the tickets for this osteogenesis imperfecta. And then the therapeutic management. So historically, it's really been supportive treatment. We have gotten some biophosphatase therapy to increase bone density and reduce fractures. It's more effective for vertebral density than it is for long bones. Rehabilitative goals are prevent positional contractures and deformities, prevent muscle weakness and osteoporosis, and prevent malalignment that limits weight bearing. So we can do lightweight braces and splints to support limbs, prevent fractures, and assist ambulation. We can do physical therapy to prevent disuse. They can get disuse osteoporosis and help strengthen muscles with physical therapy. Surgery may be used to correct deformities interfering with braces, standing, or walking. We might put rods in place in long bones for stability and deformity prevention. Nursing care and management, probably the bigger things with this is we need to handle the infant or child very carefully to prevent fractures. So we never lift the kiddo up by their ankles when we're changing their diapers. We always need to lift with the buttocks. We need to use pillows for support. We need to support the full body when turning, positioning, and holding. Avoid fear of touching. Compassionate handling is necessary. And you'll have parents that are afraid to touch their child because they're worried that they're going to hurt them. So, really good education on how to safely handle is important. We want to educate parents and children on activity limitations, self-development activities. We want to support realistic occupational planning and long-term genetic counseling. We want to use education and family support services. There is an Osteogenesis Imperfecta Foundation, and children with unexplained fractures always should be evaluated for osteogenesis imperfecta. So, careful assessment is needed to differentiate from possible abuse. So we need to think about like what was the history? Do we not have any soft tissue injury? And what are the other associated symptoms? So looking at, do we have those short stature, blue sclera, or discolored teeth, right? Those additional symptoms would kind of cue us in that it could be osteogenesis perfecta. And that is the end of this lecture. Next, I'll be doing chapter 30, neuromuscular skeletal and muscular skeletal dysfunction. Have a good day.